All right, endocrinology. So there's a correction. Remember, I told you it's the foregut, right? It should be the celiac trunk and not the SMA, right? So you have a common hepatic, which is a branch of the celiac trunk. Then you have the left gastric, okay? Celiac trunk, foregut. Midgut is superior mesenteric artery. Hindgut is inferior mesenteric artery. IMA is very important. Why? The splenic flexure is via your marginal artery of Drummond. Right? For example, if there's a colectomy that's being done, blood supply to the splenic flexure is gone, so that's a prone site for ischemia, basically, right? So the anastomosis between your left colic artery and your marginal artery of Drummond, right? That's prone for ischemia. There's also another anastomosis between your left gastric, left colic, sorry, left colic and superior rectal artery, which can give you ischemia of your rectum, okay? Now, endocrinology. So hypothyroidism. Everything slow down. Think about basal metabolic rate decreased, right? Everything slows down. What are the features? Lethargy, fatigue, weakness, cold intolerance, weight gain, constipation, hyporeflexia, dry cool skin, coarse brittle hair, bradycardia. Hyperlipidemia. Why are we having hyperlipidemia? Because we're increasing the production of cholesterol and LDL. Also myopathy. Think about weakness, cramps, myalgias, increase in serum CK, and also hyponatremia. Why? Because you have high levels of antidiuretic hormone. Where does your ADH act? In your tubules. In your kidney. Where does it act? ADH. Antidiuretic hormone.
In the distal convoluted tubule?
Mainly aldosterone is there, but ADH is in your collecting duct, right?
Collecting.
Function. Antidiuretic hormone.
So it activates your V1 receptors to reabsorb water from the tubule.
Yep, so you have V1, so you have increase in aquaporins in your collecting duct, thereby increasing water reabsorption. Good job. Other features, infertility. Why? Because you have increase in prolactin. If you have increase in prolactin, you have disruption of your menstrual cycle. Also low FSH and LH. Also cognitive impairment. Think about depression, think about hypertension. So hypothyroidism can cause aortic stiffness. Now, myxedema. Myxedema is a non-pitting edema of the skin from hypothyroidism. Why? You have hyaluronic acid deposit, your mucopolysaccharides deposit in your dermis. So basically, this one, when they deposit in your dermis, it draws the water out. That's why you have swelling. Usually in the facial area, look at this man here, you can see periorbital or facial swelling. High-yield pretibial myxedema seen in Graves' disease or hyperthyroidism. This is a special form of myxedema over the shin bone, pretibial in your legs, okay? And of course, sometimes you have myxedema coma, most fatal consequence of your hypothyroidism, which is a coma from hypothyroidism. There are different subtypes. I don't know if this is for term 4. We have primary hypothyroidism, so you have decrease in T3 and T4. What happens to TSH? Negative feedback mechanism. TSH will be high. This is central hypothyroidism is rare, right? Central hypothyroidism means there's a failure of the pituitary gland of the hypothalamus. Same cause as hypopituitarism. So basically, your pituitary gland or hypothalamus, it's not functioning, right? And remember that the master gland, your releasing hormones are from your pituitary gland. This is your master gland. So workup usually involves MRI of the brain. TSH will be low or inappropriately normal. But the high yield point here is the primary hypothyroidism. Why? Because it's the most common form failure of the thyroid gland to function due to disease or iodine deficiency, decreased T3, T4, TSH is increased. Again, high yield, know the values, not the value, but what happens to TSH and T3 and T4. Low T3 and T4, that's why it's hypothyroidism. And negative feedback, increase in TSH due to negative feedback. That's primary. Don't concern yourself about central because that's very, very rare. Okay? So what is goiter? Goiter is an enlarged thyroid. So normally the thyroid is like 15 to 25 grams. Goiter is caused by excessive stimulation of your thyroid gland, commonly seen in primary hypothyroidism. Again, low T3, T4, high TSH, and also in hyperthyroidism due to Graves' disease. Why? Because you have thyroid stimulating antibodies. Subclinical hypothyroidism, how are we going to diagnose this one? Normal free T4, but increased TSH. It's asymptomatic. Treated only if TSH is more than 10. Risk of atherosclerosis and MI. You also have euthyroid 6 syndrome. However, for this one, check for low T3. Low T3, then it is euthyroid 6 syndrome. Low T3, normal TSH and T4, euthyroid 6 syndrome. Also, check reverse T3. If you're not sure yet, you check the T3, it's low, and you're not sure, check, they're going to give you a value of your reverse T3. Then you already know if the reverse T3 is there, then the answer choice is euthyroid 6 syndrome. So the reverse T3 only arises in critical illness due to impaired clearance. So check T3. If they are low, central hypothyroidism. If they are high, sick euthyroid syndrome. No treatment for your euthyroid 6 syndrome. Primary hypothyroidism, most common cause, high yield worldwide, is iodine deficiency. But in the vignette, if they say US, the most common cause is autoimmune thyroiditis, more common in women. Antibody testing used in select areas. Don't forget your iodized salt. Okay. What's the treatment? Levo, Cyroxin. What is this? Synthetic T4. Check TSH in 6 weeks. Treat all symptomatic patients. Of course, if you're pregnant, right? Higher doses of levothyroxine. Why? Because they have higher thyroglobulin binding, thyroglobulin, TBG levels. Why? They're pregnant. It occurs in high estrogen states, like in pregnancy, and if they're using HRT in menopause. What is this mixed edema coma that we talked about? The most deadly, the deadliest outcome of hypothyroidism. So you have hypothermia, altered mental status, and organ dysfunction. This is caused by an acute event in a poorly controlled hypothyroidism. For example, if you've given opioids to a patient, or infection, or the patient is having MI, or the patient is going to surgery. So it's a combination of hypothermia, hypoventilation, bradycardia, hyponatremia. This is due to what? Severe, long-standing hypothyroidism. Those patients that is not treated by medications, or that's what do you call this? They're resistant to treatment. They can develop mixed edema coma. How do we diagnose this? Check TSH and thyroid hormone levels. For thyroid, always check T3, T4, and TSH, and expect negative feedback mechanism in order to diagnose if it's hyper or hypo. Check T3, T4 first, if they're high or low, and then check the TSH. Reverse T3 is only checked if you have euthyroid 6 syndrome. So how are we going to treat this? Mixed edema coma, T4 and T3. You can also give glucocorticoids, MECVENT, and intravenous fluids. This is a very deadly complication of your hypothyroidism. What are the causes of primary hypothyroidism? In the rest of the world, iodine deficiency. For us here, it's autoimmune, right? Thyroid thyroiditis. There are different kinds. Thyroiditis simply means a thyroid gland inflammation. It may initially cause hyperthyroidism and then hypothyroidism. The most common form is CLT, chronic lymphocytic thyroiditis, which is Hashimoto's thyroiditis. This is the most common cause of hypothyroidism in the US. Infiltration of the thyroid gland. Please know the HLAs, DR3, HLA DR5. There are antibodies that are produced, anti-TPO, thyroxine peroxidase. Question, what's the function of TPO? Thyroxine peroxidase, what does it do?
It conjugates the iodine.
Exactly, for iodination, right? It adds iodine to your T3, 3 iodines, and T4, 4 iodines. Excellent. Anti-thyroglobulin. Remember, the antibodies, they are not required to begin treatment. When you have a clinical suspicion that it is hypothyroidism, it's Hashimoto's, then you give treatment. And this can be used, the antibodies can be used to confirm the diagnosis. So in the vignette, we're going to say HLA DR3, DR5. You see anti-TPO and anti-thyroglobulin. The answer is Hashimoto's thyroiditis. The most common among middle-aged women, you have increased risk of non-Hodgkin's B-cell lymphoma. Okay, high yield for Hashimoto's, increased risk of non-Hodgkin's B-cell lymphoma. What's the treatment then if they're hypothyroid? So you give thyroid replacement therapy. You give levothyroxine. Another form of thyroiditis is subacute urticaria veins or granulomatous thyroiditis. Remember, it's a post-viral inflammation. So they have viral infection and then they develop this tender enlarged thyroid gland. Check ESR, erythrocyte sedimentation rate, and CRP. They usually increase. Why? These are the markers of inflammation in the body. If they're increased, it means there's an inflammatory process that's going on. How do we diagnose this? Urticaria veins. So check for clinical diagnosis, neck pain with enlarged thyroid and low thyroid radioiodine uptake. The rule for radioiodine uptake is, remember hot nodule versus cold nodule? Cold nodule, less uptake. Hot nodule, more uptake. Meaning, if they're uptaking the iodine, they have an increased uptake of iodine, it means they're working hard, right? If they have less uptake of iodine, which is your cold nodule, it means they are not working that hard, basically. So if you have increased uptake of iodine, we call that a hot nodule, meaning you have increased metabolism inside the cell. If we have decreased uptake of iodine, it's a cold nodule, meaning decreased metabolism of the cells. What's the treatment? Anti-inflammatory aspirin and NSAIDs usually resolves in a few weeks. Now, there's also a variant of Hashimoto's called painless thyroiditis. Let's not talk about that. That's low yield. You can also have postpartum thyroiditis. You know, when it's very self-limited after the delivery of a baby or after a spontaneous abortion. High yield fibrous thyroiditis, Riddell's. This is due to what? Fibrous deposition in the thyroid, like collagen deposition. So rock hard thyroid. Riddell's are rock hard. Often extends beyond the thyroid. You can have hoarseness, you can have trachea compression. A yield associated with IgG4 plasma cells. When you check the biopsy, look at the lower right image. This is an example of a plasma cell. When you see that, think Riddell's thyroiditis. Diagnosed by biopsy, treatment, thyroid hormone replacement. Surgery, often required to relieve your thoracic compression. If they have difficulty breathing, then do surgery. Let's talk about infiltrative thyroid disease, fibrous amyloidosis, sarcoidosis, and hereditary hemochromatosis. For iodine deficiency, you have enlarged thyroid. Why do we have enlarged thyroid? Because you have a constant elevation of TSH. This is commonly seen in regions with widespread iodine deficiency. Those people that are not near the coast in the US, like in the Midwest, right? Before iodized salt is centralized, or yeah. So there are substances that inhibit thyroid hormone production. One of them is lithium, which inhibits the release of thyroid hormone, and another one is amiodarone. Now, amiodarone, it causes hypothyroidism. So if I have excess iodine, what happens to the production of my thyroid hormones? Would it be increase or decrease? If I have excess supply of iodine, I'm ingesting iodine, what happens to my T3 and T4 levels? Will the body keep on producing thyrogens? Yes or no?
I would say it would increase.
Your body needs to protect, right? You have excess in iodine, right? So have you ever heard of the Wolff Chaikoff effect, which is protective in our body? What is the Wolff Chaikoff effect? Did you talk about this or no?
It doesn't sound familiar to me. I don't know.
Wolff Chaikoff
Doesn't
effect,
sound
right?
familiar to me either.
We have a large amount of ingested iodine, which inhibits thyroid hormone synthesis. It's protective. If we have increase in iodine, you don't want to create thyroid hormone. That's the way of the body to protect itself, okay? We call this one the Wolff-Chaikoff effect, right? Irrespective of the serum TSH, okay? That's high yield. So amiodarone can also cause hyperthyroidism. So what are we going to do if we want to prescribe amiodarone, which is an anti-arrhythmic drug, right? Class 1, class 2, class 3, class 4. Amiodarone is what class of antiarrhythmics?
Class 3.
Excellent. What's class 1? Class 1A. Your procainamide, right? B, 1B.
Lidocaine?
Good. C. Mixilidine, right? I know, there's a lot. It's like from your module, I think. Cardio module. So for amiodarone, check TSH because it can cause hypothyroidism and hyperthyroidism. Sometimes you can also have iatrogenic hypothyroidism if they remove your thyroids, right? Or if they're giving you radioiodine therapy, which damages your thyroid tissues, or if you have neck radiation. Think about patients who has Hodgkin's lymphoma or head and neck cancer, iatrogenic hypothyroidism. Now let's go to the opposite end of the spectrum, hyperthyroidism. 2 words, speeds up. Everything speeds up. Okay, hyperactivity, heat intolerance, weight loss, diarrhea, hyperreflexia, warm, moist skin, fine hair, tachycardia. Primary hyperthyroidism, increase T3, T4. What happens with TSH via negative feedback? Decrease. So low TSH with high T3, T4. Central hyperthyroidism is rare. That's low yield. This, for the lab findings, check primary, okay? So high T3, T4, negative feedback to TSH, low TSH. Causes, high yield, Graves' disease, and some others. So Graves' disease is an autoimmune disease, so you have a thyroid-stimulating antibody. So you have anti-TPO and anti-thyroglobulin antibodies. The special features, high yield, exophthalmos, look at this, bulging eyes. You have proptosis and periorbital edema. Why? Due to fibroblast and adipocyte activation. You can also see pretibral mixed edema here. This is your shin bone, right? And you can see this one here. These are fibroblasts, right? Deposition of fibroblasts on your shin bone, which stimulates the secretion of GAGs, glycosaminoglycans, right? And these GAGs, they draws in water. That's why you have swelling. So Graves' disease, exophthalmos pretibial myxedema. What's the diagnosis? Check for antibodies, TSH receptor antibodies, right? Or you could do a radioactive iodine uptake. Since it's hyperthyroidism, we expect a hot nodule, meaning iodine uptake is increased. You can see they're light up properly here, very dark, right? Increased due to what? Overactive thyroid. What's the treatment? It's a beta blocker, right? So you give it, it improves the tachycardia, or you could give others. Radioiodine thyroid ablation, surgery, and thion-amides. Thion-amides are methimazole and PTU, which inhibits production of thyroid hormone. Methimazole, most commonly used drug, and then PTU, lower risk of adverse effects, and main use is for first trimester of pregnancy. PTU, propylthiouracil, safe in pregnancy. Okay. What are the actions of your thion-amides? Basically, how does methimazole and propylthiouracil work? How do they work?
I think they block the conjugation.
The conversion, right? So your methimazole, it inhibits your conversion. Both the PTU and methimazole, it blocks the production of new thyroid hormone in your thyroid gland. So it inhibits, the PTU inhibits basically TPO, your thyroid peroxidase, which the function is to convert iodide to iodine molecule, and for incorporating the iodine molecules into your amino acid tyrosine, right? Don't forget that one. PTU, safe in pregnancy, so you can give it in pregnant women. Methimazole, no, very, very bad. What are the adverse effects of your thion-amides? High yield agranulocytosis, drop in WBC, hepatotoxic. So check their liver functions, right? So CBC and LFTs. Monitoring of WBC is controversial. Another treatment for Graves, radioiodine ablation. So you give an oral capsule. That capsule is concentrated iodine. Then you give it in the thyroid. Then you have ablation. However, for this one, it requires lifelong replacement therapy, and it may lead to worsening orbitopathy. For surgery, thyroidectomy, what's the major risk? It can cause hypoparathyroidism. You might accidentally remove the parathyroids. Now let's do an anatomy question. Thyroid glands, how many lobes? How many lobes? 4 lobes. Left, right, middle, and pyramidal lobes. Blood supply, 2 blood supply. What are those? What's the blood supply of the thyroid? Can you hear me, guys?
Yeah, I can hear you. I just don't
What's
know.
the blood supply of the thyroid? Superior thyroid artery and inferior thyroid artery. Superior thyroid artery, what branch? So it branches off what main artery?
The external carotid.
External carotid, excellent. How about the inferior thyroid artery? It's a branch of what? Remember that silly thing that we've memorized, the thyrocervical trunk? That's it. It's a branch of the thyrocervical trunk. What attaches the thyroid to the trachea? What ligament is it? So these are basic term 1 questions, anatomy questions. What ligament attaches a thyroid to the trachea? Ligament of Berry, right? What can we find behind the cricopharyngeal muscles? Remember your thyroid, you have the tracheoesophageal groove, right? Behind that. What nerve traverses that tracheoesophageal groove? Behind the thyroid.
Was it the laryngeal?
Of course, the recurrent laryngeal nerve, right? What's the blood supply of your parathyroid gland? Where does it get its blood supply? Inferior thyroid artery, which is a branch of thyrocervical trunk. How many venous supply do we have on the thyroid? 3. Superior thyroid vein, middle thyroid vein, inferior thyroid vein. So guys, I'm just telling you the basic anatomy of the thyroid, right? Basic term 1 stuff, so that we're on the same page. Okay. So what can we do? Thyroidectomy, you said. We remove the thyroid. Okay, we remove the thyroid. So what? Think about post-operative hypocalcemia. Why? Because the parathyroids are there, right? You have 4 parathyroids. Some people have 5. Yes. Some people have more than 4 parathyroid glands. So think about hypocalcemia. You might accidentally cut one of the parathyroids. So this is the most common complication of thyroidectomy. High yield paresthesia of the lips, mouth, hands, and feet. Hypocalcemia, right? Muscle twitches or cramps, right? What are we going to give? IV calcium gluconate. You have reducing calcium, you give calcium. So IV calcium gluconate. For Graves' or Betopathy, the exophthalmos, we need to give glucocorticoids, right? That's the mainstay of treatment when it is very, very severe, your glucocorticoids. For toxic adenomas, we talk about thyroid nodules. There are different kinds. You can have palpable nodules, nodular goiter, whatever. That's not important. The treatment for toxic adenomas are the initial treatment are beta blockers, which inhibits peripheral conversion, right? And thion amides, your PTU and methimazole. However, the preferred therapy for most patients are radioiodine ablation. Okay, sometimes surgery in select patients. We talked about Wolff-Chaikoff effect. Now we need to talk about the Jod-based Dow phenomenon. These are 2 high yield when we're talking about the thyroid. As I've said before, Wolff-Chaikoff effect, protective. The body is protective. You have excess iodine, therefore the body needs to decrease production of your thyroid hormones. Now, there's another thing that's called Jod-based Dow phenomenon, wherein excess in iodine can cause parathyroidism. Now, the Jod-based Dow phenomenon, it occurs due to overactivation of the entire thyroid gland. Or more commonly, if you have like autonomous nodules within the gland after iodine repletion without feedback control from the pituitary gland. So this is an escape from your protective Wolff-Chaikoff. Okay, this is called a Jod-based Dow phenomenon. Okay, so you have autonomous nodules within the gland after iodine repletion without feedback control from the pituitary gland. We call this iodine-induced hyperthyroidism, a rare cause of thyrotoxicosis. Okay, you're escaping the Wolff-Chaikoff effect, Jod-based Dow phenomenon. Often occurs in regions of iodine deficiency, right? Often occurs in patients with toxic adenomas. If you're giving contrast dye or if you're giving amiodarone, they might have this phenomenon, Jod-based Dow. So in amiodarone, it can cause hyperthyroidism, as I've said. So type 1 and type 2. Type 1, pre-existing thyroid disease, and type 2 without pre-existing thyroid disease. How do we manage them? Stop amiodarone, of course. Then you do radioiodine uptake, RUI. And then type 1 is for beta blockers, thionamides, ablation or surgery. Type 2 is glucocorticoids. Some other causes of hyperthyroidism, early thyroiditis, and exogenous hyperthyroidism. Okay, look at this image. What are we going to do? Primary hyperthyroidism, increased T3, T4, decreased TSH. Are there symptoms of Graves? Are they goiter and exophthalmos? Yes or no? Yes, then it's Graves. No? Okay, let's check antibodies. If it's positive, it's Graves. If it's negative, check iodine scan. If they're high, then it's Graves. Or if it's nodular, toxic adenoma. If they're low, it's thyroiditis or exogenous T4. The most deadliest life-threatening event of hyperthyroidism is called Thyroid Storm. It is usually precipitated by acute event like surgery, trauma, or infection. You have a massive catecholamine surge. You have an increase in your thyroid hormone levels. Everything speeds up, guys. So you have fever, delirium, tachycardia, warm skin, tremor, hyperglycemia, hypercalcemia. What can we give? Propranolol. Why? Beta blocker. It blocks peripheral conversion of T4 to T3. But what is more active, T4 or T3?
T3.
T3, of course. PTU preferred over methimazole. Why? Because PTU also blocks peripheral conversion of T4 to T3. And glucocorticoids, of course, is a steroid. It reduces inflammation if Graves' disease is present. How does it reduce inflammation? Your glucocorticoids? By inhibiting what enzyme? Phospholipase A2, right? Don't forget, remember that? COX and the lipoxygenase. Before that, from phospholipids, you have phospholipase A2, right? Don't forget catecholamine synthesis. That's very high yield. Again, iodine. You give them iodine, or they can go to ICU. So for thyroid nodules, why are we concerned about the nodules? Because you can have thyroid cancer. If you have a nodule, you have a 5% to 10% risk of developing thyroid cancer. So what's the workup? Check TSH. Is it high or low? If it's low, check RUI, radioactive iodine uptake scan. If it's positive, then it's hyperthyroidism. If it's normal or high, check for sonogram. If it's still unclear, if it's positive, then you do fine needle aspiration. If it's not, you do monitoring. You check for the measurement. If it's low TSH, then it's subclinical hyperthyroidism. Also, it suggests hyperfunctioning nodule. If it's normal or high, think about malignant nodule. The higher the TSH, the higher the likelihood for cancer. For RUI, we talk about this, hot and cold. Remember that Katy Perry song? You're hot and you're cold, so hot. You have greater uptake than surrounding tissue, meaning hyperthyroidism. Cold nodule, less uptake, meaning they are not probably hypothyroidism if you have a cold nodule. It may require FNA and follow-up testing with ultrasound. What can we see in an ultrasound then? If it's cystic lesions, you can see fluids. It's benign. Suspicion, if it's very suspicious, you do FNA. If they're large, microcalcifications, irregular margins, or extrathyroidal invasion. Again, that's a workup. So we do FNA here. I think this is low yield. This is for step 2. Now, high yield thyroid cancers, the different kinds, right? They're going to give you a slide, and you need to check. You need to correlate that pathological slide with the actual signs and symptoms. So papillary carcinoma, most common P, most common form, right, of thyroid cancer. You have increased risk with prior radiation exposure. Think about the survivors of the atomic bomb detonation in Japan. Think about in Chernobyl nuclear power accident during USSR, right, the Soviet Union. If they have, sometimes it is identified on imaging and diagnosis is made after fine needle aspiration. So excellent prognosis, it's most common, treated with So you can give post-operative levo Cyroxin, which prevents TSH rise, which inhibits cancer growth. Or you can also give radioactive iodine ablation. We're gonna destroy the thyroid tissue via radioactive iodine, which eliminates your metastatic cells. Another one thing is your follicular carcinoma. Wait a minute, I need to summarize for you the papillary carcinoma. Okay, here is the key word I want you to remember. Papillary thyroid cancer. Write it down. It's not on the slide. Papillary cancer, right? 7 P's. Uno, popular, most common. Dos, samoma, bodies. Tres, palpable lymph nodes. So they spread most commonly by lymphatics, right? Cuatro, iodine. Cinco, positive prognosis. Sais, post-operative iodine scan to diagnose or treat metastasis. Siete, third, FNA not, NOT. So FNA cannot diagnose.
Nick, can you hear me?
Nick, you froze up for like a minute.
Hello?
Nick, you froze up for a couple minutes.
Also, did you get the 4 F's of follicular cancer?
You froze up after you said siete?
Oh, okay. Oh my God.
You froze up for me at the 6P. Sorry.
Okay, let's go back to that slide then. So I want you to know for exam purposes, right? 7 P's of papillary thyroid cancer. Uno, popular, most common.
I'm not seeing your presentation anymore. Is everybody else seeing it? Is it just me?
I can't see the presentation either.
All right. Okay, wait a minute. All right. How about now? Yep. It's not on the slide, actually.
It's back. I just didn't want you to go through the whole thing
Oh.
thinking we're seeing it and we're not. Thank you, Nick.
So it's not on the slide, so I want you to write it down, okay? This is important. 7 P's of papillary thyroid cancer. They begin with letter P, of course. So 1, common. 2, samoma. 3, palpable lymph nodes. So they spread most commonly by lymphatics. 4, positive iodine uptake. 5, positive prognosis. 6, post-operative iodine scan to diagnose or to treat metastasis. 7, pulmonary metastasis. We're good? Yes or no? Yes?
Yes, sorry, what was 6 again?
6 is post-operative iodine scan to diagnose or treat metastasis. And then 7 is pulmonary metastases. Just remember those 7 P's, you're going to be golden. That's how I remember them. Okay? Okay, next. Follicular. For follicular, 4 F's. Okay, they all begin with letter F. Uno, far away metastasis, meaning they spread hematogenously. Dos, female predominance, 3 to 1. Tres, FNA not, meaning FNA cannot diagnose this cancer. Okay? Cuatro, favorable prognosis. We're good? For follicular carcinoma, that's how I remember them. So we have 7 P's, 4 F's. Now I give you for medullary carcinoma 4M. Okay, it's not on the slide. Please write it down. 4 M's of medullary carcinoma. You ready? Uno, MEN2. Second, dos, amyloid. Third, median lymph node dissection. Cuatro, modified neck dissection if the lateral nodes are positive. That's your 4 M's of your medullary carcinoma. Why is it medullary? Because it's a cancer of your parafollicular C cells. It produces calcitonin. What's the treatment then? Total thyroidectomy. What are we going to monitor? Calcitonin, serum calcitonin monitoring. Men syndrome. We talked about this one before. Elective thyroidectomy, the difference between MEN1, MEN2A, MEN2B. Now, for anaplastic carcinoma, this is occurs in elderly. It is very, very highly malignant. What can we see? Dysphagia, hoarseness, dyspnea, poor prognosis. Treatment is surgical. Primary thyroid lymphoma is always associated with CLT, or chronic lymphocytic thyroiditis, or Hashimoto's. All right. Now let's talk about hyperaldosteronism. So there are different kinds. Primary hyperaldosteronism, increased aldosterone, not due to RAS. It is due to an adrenal adenoma, most common etiology, Cohen's syndrome, rarely adrenal carcinoma. So what happens? Increased circulating volume, increased aldosterone, right? You have increased sodium reabsorption in the distal nephron, thereby increasing circulating volume, which causes hypertension. You are wasting potassium, hypokalemia, and you're increasing H+ excretion, thereby developing metabolic alkalosis. So primary hyperaldosteronism, increased aldosterone, hypertension, hypokalemia. There's also such thing as aldosterone escape. It's a mechanism of the body wherein excess aldosterone does not lead to volume overload. This is due to what? HL natriuretic peptide, which increases the sodium and free water excretion. I just want you to know the antagonist for aldosterone is HL natriuretic peptide. The result is diuresis, thereby getting you into normal volume status. What are the clinical features of primary hyperaldosteronism, resistant hypertension, hypokalemia? Other diagnoses, you can do PRA, PAC, and the ratio of your plasma renin activity and plasma aldosterone concentration. All right, let's do some common endo diseases. Get your pens out. Let's see. Number 1. MC, you have a pituitary adenoma. What is this? What are we thinking?
Cushing's disease?
Careful. Consider this in pregnancy. If someone is pregnant.
Sheehan syndrome?
Amenorrhea,
Prolactinoma.
Excellent, excellent. This is a prolactinoma. So considering amenorrhea, right? What's the treatment then?
A dopamine agonist.
Exactly. Give me an example of a dopamine agonist.
Bromocriptine or cabergoline.
Yep, excellent. So if you have hypopituitarism, which hormones are lost first? I know this is kind of like trivia question. Okay, these are the hormones that are lost. First, you lose FSH and LH. Then you lose growth hormone. Then you lose TSH. Then you lose ACTH. I know it's not fair. It's kind of like a trivia question. But I wanted to know if you have hypopituitarism, the first thing that is going to be lost is FSH and LH. So think about reproductive system. Right? What happens to the testosterone and estrogen levels? Okay. Next, polyuria, polydipsia, hypernatremia, hyperosmolar, dilute urine. You have polyuria, polydipsia, hypernatremia, hyperosmolar urine, dilute urine. What are we thinking of? It's dilute, guys.
So it's like diabetes.
Diabetes insipidus.
Diabetes insipidus. Excellent. This is due to lack of what? Why do we have diabetes insipidus? Lack of antidiuretic hormone, right? So you need to do a water deprivation test. So if I do water deprivation test, how do I know if it's central or nephrogenic? What happens to urine osmolarity?
It would increase in central.
Careful. I said water deprivation test. I didn't say desmopressin test. There's a big difference, guys. Okay? Water deprivation is different from a exogenous desmopressin test. Okay? Careful, careful. I'm talking about water deprivation test. You restrict water. You don't give them water. Okay? Big difference. In central, the urine osmolarity still decreases status post water deprivation test. Okay? Now, what if I give desmopressin test? There you go. What happens to urine osmolarity in central in a desmopressin test? What happens? In central, the urine osmolarity increase or decrease?
Increase.
Excellent, increase. In nephrogenic, what happens to urine osmolarity? Decrease. Status post exogenous desmopressin administration. What's the treatment then for nephrogenic DI? What can we give in someone who has nephrogenic DI? We can give hydrochlorothiazide. Side effects of hydrochlorothiazide, your thiazide diuretics. Hypergluc, guys. What is hypergluc? Guys, hyperglycemia, hyperlipidemia, hyperuricemia, hypercalcemia, right? Hypergluc. So you can give this to someone who has osteoporosis, actually, thiazide, diuretics. How about amiloride? What's the mechanism of action of amiloride? Your amiloride. What's the mechanism of action?
Is that a potassium-sparing diuretic?
Is it the potassium sparing diuretic? What are we thinking? What is amiloride? It blocks what channel, guys? ENaC, right? It blocks the ENaC channel, your epithelial sodium channel in the late distal tubule, the connecting tubule, and the collecting duct. So you reduce the absorption of your sodium ion from the lumen of the nephron, and also it, what? Potassium sparing, it reduces excretion of potassium ion into the lumen. Good job. Okay, you can give that in nephrogenic. Okay, next. You have low TSH but high T3 and T4. What's the next best step? Remember that diagnosis, that treatment workshop? So you have low TSH, high T3, T4. What's the next best step? You already check a TSH. That's the first step. It's low. So what's the next best step?
Would it be to decrease the amount of T4 that gets converted to T3?
In terms of that algorithm, what are we going to do next? So remember, the first test is always check for TSH. For any kind of thyroid diseases, always check TSH. Now you checked it and it's low. You also check T3, T4, they are high, right? So what's the next best step? What are we thinking then? After TSH, we need to do another test.
The iodine uptake.
Excellent. The iodine uptake. So if it's increased, then we can say it's Graves. If it's decreased, then it can be like a thyroiditis. So if it is Graves, what's the treatment? You give propranolol, PTU methimazole. What's the treatment of thyroid storm?
PTU,
Plus what?
propranolol, and iodine.
Exactly. Or they're gonna put in Lugol's solution. It's the same thing. Iodine is the same thing as Lugol's solution. So don't be confused. Okay. Next, workup of a thyroid nodule. As I've said before, doctor, I have this thing on my throat. You check the thyroid. What's the first step in the workup of a thyroid nodule? Always. What's the initial step or the basic step? What is it?
Measure the thyroid levels.
Check TSH. TSH. Okay, high yield, always do that first before doing anything. Initial step, that's the wording that they're gonna use. Best initial step. Then, we check the TSH. It's low. What's the next best step? Someone said it before.
The iodine uptake test.
Excellent. Why? Because we need to know what kind of nodule is it. Is it hot or not? Hot or cold? Then we check the nodule. Oh, it's normal. It's not hot. It's not cold. It's normal uptake. What's our next step then? Do you want to check what's inside the nodule? Yes? We or no? If it's normal.
So, oh, if it's normal, never mind.
So if it's normal, we can do FNA, right? If it's benign, leave it alone. Don't do anything. If it's malignant, we can surgically excise and check the pathology. If indeterminate, we can rebiopsy. If it is cold, we can excise and check the pathology. Now, these are the cancers, right? Papillary. Spreads via lymph, Samoma bodies. Don't forget the 7 P's that I talked to you about. Follicular, the 4 F's. Spreads via blood, surgically excise whole thyroid. Medullary, the M's. Men2, so look for pheochromocytoma, hypercalcemia. Look for amyloid and calcifications. Anaplastic, the deadliest of them all, 80% mortality in the first year. Thyroid lymphoma, Hashimoto predisposes to it. So if you have Hashimoto, it predisposes you to have thyroid lymphoma. Adrenal issues. Okay, osteoporosis, central fat, diabetes, hirsutism. What are we suspecting this patient have?
Cushing syndrome.
Cushing's. What's the best screening test?
ACTH levels.
Best screening test. We can do ACTH levels, exactly, but the best screening thing, it's all about the wording, right? The wording of the vignette. Best screening test, right? You can do dexamethasone test, or you can also do a 24-hour urine cortisol test. You check them, they're both abnormal, so it diagnoses Cushing's syndrome. What's the next best step? So the first one is 1 milligram. I don't know if this is for step 1, but the first dexamethasone suppression test is 1 milligram, and then the second one is 8 milligrams, right? If you suppressed it to 50%, then it is a diagnosis of Cushing's, right? Pituitary adenoma, that's the cause of the Cushing's. If there's no suppression, either it's an adrenal neoplasia or an ectopic ACTH producing tumor. So your next best test would be plasma ACTH. Also check the CT if the patient is a smoker, and also abdominal CT. If the patient has weakness, hypotension, weight loss, or hyperpigmentation, think adrenal insufficiency. What's the best screening test for adrenal insufficiency? Cosyntrophin stimulation test, right? Most common cause, autoimmune. Think about Addison's disease, right? What's the treatment for Addison's? Sodium chloride resuscitation, or a long-term replacement of your dexamethasone and fludrocortisone. Workup of an adrenal nodule, best first step is check functional status. Please note the diagnosis and the features and the biochemical tests that you're gonna use for each diseases, right? Pheochromocytoma, so we have high blood pressure, catecholamine symptoms. So you check urine and plasma-free metanephrines. What is before surgery? What can we give in patients who has pheochromocytoma? What can we give?
Is it phentolamine?
Phentolamine. Final answer?
I think so.
Yes. Say it with confidence, please. You already know it. It's all in your head. Phentolamine. Why?
It's going to decrease the blood pressure. It's an alpha-1 blocker.
Exactly. Reversible or irreversible?
Reversible.
Reversible. Good job. See? I told you. You are all smart. So before surgery, you give them phentolamine. And then during surgery, we can give them? What's the other one? The irreversible.
It's phenoxybenzamine, right?
Phenoxybenzamine. Excellent. Irreversible block. Good job. Okay, so you check urine and plasma-free metanephrines, pheochromocytoma. For primary aldosteronism, think high blood pressure, low K. Remember, aldosterone, it's a potassium wasting, right? And check the aldosterone to renin ratio. If there is an adrenocortical carcinoma, think about the virilization or feminization. Check urine 17. Steroids, Cushing's or silent Cushing syndrome, Cushing symptoms, check the test by overnight dexamethasone test. So if the patient has a non-functional adrenal nodule and it's small, you just observe them with CT scan every 6 months. If it's more than 6 centimeters or the nodule is functional, we can have surgical excision. Okay, now let's move on to parathyroid disease. What disease can cause perioral numbness, Chvostek, that's a typo, please. It's a Chvostek trousseau, status post thyroidectomy. What are we thinking?
Hypocalcemia.
Yep, or hypoparathyroidism. So for your OSCE guys, Chvostek sign, how can I elicit this in a patient? Chvostek sign.
I think that's when we take a pen or fingers and run it by the patient's cheek.
And what will happen? Good.
We'll see like the random spasming of the facial muscles.
What nerve is stimulated? If you tap the cheek, what cranial nerve?
Facial nerve.
Facial nerve, 7. Good job. How about trousseau sign? For OSCE, how are we going to elicit a trousseau sign?
That's with the blood pressure cuff, and but as you pump it, I guess the hand cramps up or curls towards you or the patient.
Okay, so you have carpopedal spasm. You can see the hands like having spasms. Why?
It's due to the hypocalcemia.
Yes, so you inflate the cuff, the sphygmomanometer, above the systolic blood pressure, right? So you already know the systolic blood pressure of the patient, then you inflate it above that within 3 minutes. Okay, within 3 minutes, and you can see like pattern. So the sign is observable as carpopedal spasm, basically. All right, so status post thyroidectomy, as I've said before, if you remove the thyroid, you can remove the parathyroid. Next one, kidney stones, constipation, abdominal pain, or psychiatric symptoms. Why do we have psychiatric symptoms now? What is this?
Hypercalcemia or hyperparathyroidism.
Hyperparathyroidism. Excellent. How many parathyroids are there? How many parathyroids are there? A1, D2, C3, D4.
4.
4. What's the embryological origin of your superior parathyroid glands? A, first pharyngeal pouch. B, second pharyngeal pouch. C, third pharyngeal pouch. D, fourth pharyngeal pouch.
4th.
4th. How about the inferior parathyroid gland?
The 3rd.
Excellent. I'm impressed. Wow. What supplies blood to all of the 4 parathyroid glands? What supplies blood to all 4 parathyroid glands? Think thyrocervical trunk. Inferior thyroid artery. What's the most common cause of hypercalcemia in outpatients? We talk about this one. Hyperparathyroidism. What cell types produce PTH? What cell type produces PTH? Where's my anatomy person? Again, please.
Is it the folliculars? No, that's the ones that has the receptors.
You're right. The parafollicular cells, your chief cells.
Oh, it is. Oh, okay.
You're right. You're
Okay.
right. You're right. Excellent. What are the major actions of PTH? What happens to blood calcium if we have increase in PTH? So you have increase in blood calcium levels. What happens to phosphate?
It
Decrease.
decreases.
Decrease. Remember, phosphate trashing hormone, PTH. Where is calcium absorbed in the body? I know, right? I'm just asking these random questions. Sorry, guys. Where is calcium absorbed in the body?
Yeah.
Where do you think?
So it can be absorbed in the GI or in the bones.
So specifically duodenum or in the proximal jejunum. So for hyperparathyroidism, there are three types: primary, secondary, tertiary. Primero, segundo, tercero. Primero, you have increased secretion of PTH by the parathyroid gland. So you have increase in calcium and low phosphorus. For secondary, think about renal failure or decreased GI calcium absorption. Think about rickets. Think about osmolation. Think about anything that results in calcium wasting. Your body is wasting calcium. Think about all of those pathologies. That's secondary. Then there's a low yield one, but I've seen a question about this, tertiary hyperparathyroidism. This is due to overcorrection of your secondary hyperparathyroidism. Okay, let me see if you know this. Imaging for the parathyroid. What's the best scan that we're going to use for the parathyroids?
Would it be CT?
I don't know if you know this. A sestamibi scan. This is your technetium thallium subtraction scan. Okay, sestamibi, think about thyroids. What is the most common cause of primary hyperparathyroidism? I should have structured my review like this one. This is a good one. What is the most common cause of primary hyperparathyroidism?
Would it be an adenoma?
Excellent. This is a much better way of review, right? Rather than me talking, listening to my voice. Okay, other etiologies aside from adenoma. So you have adenoma, you have carcinoma, which is less than 1%, and you have hyperplasia, right? What are the signs and symptoms of primary hyperparathyroidism, hypercalcemia? So stones, bones, groans, and psychiatric overtones. So you have kidney stones, bone pain, what else? Muscle pain, depression, other symptoms, right? What can we see? Okay, high yield. If they're giving you an X-ray, right? And you think it's primary hyperparathyroidism. But the question is, what plain X-ray findings are classic for hyperparathyroidism? What can we see? Specifically in the hands. We can see subperiosteal bone resorption. That's it. I don't know if you talk about familial hypocalciuric hypercalcemia. That's not high yield. Let's see this one. Blah, 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 blah. Carcinoma. I don't think so. Post-op complications. Like if you remove the parathyroid, what are the possible complications? Of course, hypocalcemia. Also think about the recurrent laryngeal nerve injury, right? Because it's in the tracheoesophageal groove. Also neck hematoma, and also superior laryngeal nerve injury. So they can't have pitch on their voice. So it's always low. They have a low voice. They can't modify it. That's a superior laryngeal nerve injury. What are the signs of hypocalcemia? We talk about this. Perioral tingling, that's the first sign. Paresthesia, then you have a Schwastek, Trousseau, and tetany. What's the treatment for hypoparathyroidism? We give IV calcium. All right, I want to rattle your brains for a couple of minutes here. So tell me the correct diagnosis, okay? Let's have an experiment. 50-year-old female with parathyroid hyperplasia, jejunal ulcers, and loss of peripheral vision. So we have a 50-year-old female with a parathyroid hyperplasia, jejunal ulcers, and loss of peripheral vision. A, parathyroid carcinoma. B, familial hypocalciuric hypercalcemia. C, MEN1. D, MEN2A.
I think it's MEN1.
Why do you think it's MEN1?
The pituitary adenoma would be that peripheral vision loss. You have the hyperplasia, and then the jejunal ulcers would be from the gastronoma.
Excellent, guys. I'm so proud of you. You're ready. You're ready for the test. And don't forget, for parathyroids, it's a sestamibi scan for that one. So we talk about men, right? So if, for parathyroid disease, you diagnose it with FNA if there's suspicious nodules. You can use sestamibi scan. That's the answer here, the question mark. So treatment, surgical removal, or if hyperplasia, remove all 4 glands. And, this is high yield also. When you go to surgery rotations, you implant 1 parathyroid gland in the forearm. That's one of the treatments, so that it can continuously secrete your PTH. Okay, good. MEN1A, pituitary adenoma, parathyroid hyperplasia, pancreatic islet cell tumor. MEN2A, parathyroid hyperplasia, MTC, pheochromocytoma, and then MEN2B, medullary thyroid cancer, pheochromocytoma, and then marfanoid habitus. Let's talk about diabetes. How do we diagnose diabetes?
So we would need like HbA1c greater than 6.5%, blood glucose, I believe it's higher than 200, fasting blood glucose higher than 120.
Excellent, excellent. May I know your name?
Valeria.
Again, please?
Valeria.
Valeria. Okay, Valeria. Wow. So you diagnose diabetes, you have fasting blood glucose, as she said, more than 126. You do it twice. You have a 2-hour oral glucose tolerance test, more than 200. You can also do a random blood glucose of more than 200, plus, of course, signs and symptoms. Polyuria, polydipsia, polyphagia, and then you have blurred vision. Now, the patient comes in. The patient has nausea, vomiting, abdominal pain, Kussmaul respiration. What is Kussmaul respiration? What is this? Kussmaul respiration, Kussmaul breathing?
Shallow and rapid.
Is it shallow or deep?
Or deep. Yeah, rapid, deep breathing.
Rapid breathing. Why? You have acidosis, right? So your body have become too acidic.
Trying to get rid of the acid.
Excellent.
Yes, CO2 exhalation.
Expel carbon dioxide, the body starts to breathe faster and deeper. So that's your Kussmaul breathing. What do you think is the diagnosis, this one, for this? Blood glucose is 400.
DKA.
DKA. How do we diagnose?
We would look for ketonuria.
Ketones in the urine.
Ketonuria in the blood and urine. Excellent. Hyperkalemia. And what else?
Proteinuria.
Proteinuria, of course.
Elevated bicarb.
What is this? I'm thinking about glycosylated
30%.
products and products, right? Glycosylated end products. Your AGME, glycosylated, advanced glycosylated end product.
Yeah,
Sorry.
age products.
Yes. Don't forget that one. Advanced. So these are proteins that become glycated as a result of exposure to sugars. Think about your hemoglobin A1C. Right? We're measuring hemoglobin that is conjugated to conjugated to sugars, right? The hemoglobin that has become glycated as a result of exposure to sugars, right? Hemoglobin A1C. So they are biomarkers implicated in aging or many degenerative diseases, for example, diabetes or atherosclerosis, sometimes CKD and Alzheimer's disease. So what's the treatment then for someone who has a DKA? So DKA, what kind of, is it acidosis, alkalosis?
Acidosis, it's in the name.
Metabolic, respiratory.
Metabolic.
An ion gap, not an ion gap.
High.
High an ion gap, metabolic acidosis. Excellent. How do we calculate an ion gap? Sodium minus the sum of chloride plus bicarb. All right. Other causes of high anion gap, metabolic acidosis. Aside from DKA, methanol poisoning, ethylene glycol poisoning, what else?
Urema.
Exactly. Good job. Go. What else?
It's the mud piles, right?
Yes. Good job. So methanol, M, uremia, D, DKA, P, paraldehyde, I, iron. What else is in there? Isoniazid, L, lactic acidosis, E.
Inborn error.
Yes, ethanol, ethylene glycol, S, salicylate or aspirin, right? Those are your mud piles. How about the other side of the coin? Your metabolic alkalosis. Oh, no, your normal anion gap.
It's the
Acidosis.
fused cars.
Go ahead.
Fistula. Uretogastric. The saline, the endocrine.
Excellent.
Like Addison's,
Good job.
hyper-PTH,
Yes.
diarrhea, carbonandrase inhibitor, ammonia chloride, and renal tubular acidosis.
Excellent.
And spironolactone.
Yes, there's a lot. So you have non-ion gap, like a used part. That's mnemonic. Like you have urinary diversion, small bowel fistula, extra chloride, diarrhea. You have pancreatic fistula. You have Addison's, acetazolamide. You have renal tubular acidosis, or different kinds, and then tenofovir and topiramate can cause your non-ion gap metabolic acidosis. Excellent. Good job. So how are we going to treat then, guys? DKA. So we need to give insulin drip, right? Bolus and then drip, high volume normal saline. And then you add potassium once the patient is peeing. And then you can add glucose if the blood glucose is less than 200. Okay. Next one. Patient comes in. Polyuria, polydipsia, profound dehydration, confusion and coma with blood glucose of 1,000. Polyuria, polydipsia, profound dehydration, confusion and coma with blood glucose of 1,000.
It's the hyper-osmolar state, or
Excellent. HHS. So what's the treatment for this? High volume fluid and electrolytes, and you may require insulin. High yield, major cause of death of diabetic patients.
MIs.
Excellent. Cardiovascular. Good job. Cardiovascular disease. So important screening, right? I think I might, this is the end. I'm gonna do reproductive for tomorrow. Okay, because my battery is 15%. Okay, for the heart, how do we screen? So we need to check LDL, right? If LDL is less than 100, blood pressure is less than 130/80. For kidneys, what are we checking for kidneys? Microalbuminemia, right? Check for that. And start them with ACE inhibitors. Example of ACE inhibitors. Examples of ACE inhibitors.
Lisinopril.
Prills, captopril, lisinopril. Side effects.
Dry cough.
Dry cough. They always love that one, right? Dry cough. And then check for the eyes, right? So proliferative retinopathy. All right, what can we see? Neovascularization in your vitreous humor. What happens to the nerves? We need to check also podiatric exam annually, right? We need to check. Check with also what happens to the GI tract. In persons who have diabetes, what happens to the peristalsis? Increase or decrease?
Decrease. You get gastroparesis.
Excellent. Good job. Gastroparesis. What's the treatment? What's the treatment for gastroparesis? Come on.
Myosin or the metachloro. I don't remember the rest of it.
Metoclopramide. You're almost there. Good job. What is metoclopramide? Mechanism of action. What is dopamine agonist or antagonist?
So it's a dopamine receptor antagonist. So
antagonist.
It's Parkinson's.
Good job. It is used to treat severe diabetic gastroparesis. Side effects. Before my computer shuts down. Side effects of metoclopramide.
Extrapyramidal effects.
Well, you can also have that, but the most common side effect is like drowsiness, dizziness, tiredness, like agitation, headache, and diarrhea. So metoclopramide, that's the generic name. Then the other name is Reglan. Reglan, it's the same thing as metoclopramide. All right, or erythromycin. Don't forget, for gastroparesis, you can give metoclopramide or erythromycin. So what else can they have to check the nerves? So diabetes can also have problems with the nerves, right? So you check the feet, the podiatry exam, you check gastroparesis, also palsies. What cranial nerves are affected usually in diabetes? Let's go to term 2, right? This is term 2. Yep. Cranial nerves 3, 4, and 6. They're affected. Are they motor or not? Are they efferent or afferent nerves? Guys.
Oh, so you're saying 3, 4, and 6 are affected in diabetics?
Yes, they're most common palsies in someone who has diabetes. So you need to check cranial nerves 3, 4, 6. My question is basic anatomy. Efferent or afferent? Motor or sensory?
Efferent, they're motor.
Excellent. There are motor. Why? Remember, they control the muscles, right? Of the eye. You have 3 pairs of antagonistic muscles, right? So cranial nerve 6 innervates what muscle? 6, LR, lateral rectus, right? 4. Superior oblique, right? 3, the rest. Okay, so what if I have a palsy of the primary presenting symptom? If you have a damage to your cranial nerves 3, 4, and 6. I told you that they are muscles of the eye. They control the antagonistic muscles of your eyes. They are efferent motor nerves. So what is the
So
most common
ocular and
presentation?
orbital muscles.
What's the most common presentation then? So you have weakness of the eye muscles, right? So
Oh, he died.
Did he say he's gonna finish tomorrow with reproductive?
Yeah, he said that.
Should we stop the recording?
I think so. I think he was done.
Yeah, I think he died. His computer.
Yeah, will someone post the video?
I'm not sure how to post it. I'm not the one recording.